Patient comes to the doctor, has a TSH that is 5, has symptoms, and the doctor, without further investigation, will just start that patient on levothyroxine. And
Right.
the patient is going to be labeled hypothyroid for the rest of their lives. And
Yes.
they will blame everything that's wrong with them to the hypothyroidism that, in fact,
Yes.
they might not have.
Welcome to Dr. Ruscio Radio, providing practical, science-based insights into health, exploring the importance of nutrition, lifestyle, and gut health through conversations with experts, research reviews, and personal stories. We break through the bias and the noise to bring you simple, trustworthy information that matters. Hi, everyone. Today I speak with Dr. Antonio Bianco, who is an MD, PhD, and this was the best conversation on hypothyroidism and thyroid health I have ever had. He is a very well-read, open-minded, progressive, but also evidence-guided provider. He's published over 200 papers and was the former president of the American Thyroid Association. He received his MD from Santa Casa Medical School and a PhD in human physiology at the University of Sao Paulo in Brazil. He's also written a book called Rethinking Hypothyroidism. And if I were to write a book, this would be the book, because as you'll see through our conversation, we see eye to eye on pretty much everything. And this is an approach I think you as a healthcare consumer need. We discuss how you correctly diagnose hypothyroidism and why that diagnosis is so crucially important so that you don't become incorrectly diagnosed and then go on lifelong thyroid hormone that you don't need. So firstly, giving you the diagnostic criteria so you can get the diagnosis correct. Secondly, we discuss T3, what that means and how do we interpret it. We do the same thing for TPO antibodies. And then finally, we come to what to do if you are on thyroid hormone, but you're still having symptoms. And conversely, what to do if your thyroid labs are normal, but you're having symptoms. There are answers to all of these questions. There is the ability to heal and to improve how you're feeling. But sadly, there's a lot of spin and there's a lot of zealotry in the thyroid space. So I would really encourage you to go through this interview, to take notes, and if you need help, consider purchasing his book so that you can have guidelines that are open-minded on the one hand, but also evidence-guided by science on the other. I hope that you will enjoy this conversation as much as I did. And now we will go to the interview with Dr. Antonio Bianco. Hi, everyone. Today I'm here with Dr. Antonio Bianco, and we're going to be discussing hypothyroidism and hopefully helping you with what to do and perhaps most importantly, what not to do. It seems there's more bad advice circulating than there is good advice. And Antonio, I really appreciate your work in terms of someone who's performing actual clinical research. So I have no doubt we will have a lot of pearls for people today.
Thank you. Thank you. It's a great pleasure to be here with you. Thank you, Michael.
And I'll do your intro ahead of time. So we'll skip over your background, which is quite impressive. So people will get that preloaded. But, I guess when we zoom way out, the way I look at this with hypothyroidism is for people with symptoms or maybe even with the diagnosis, I would like for them to have the right diagnosis and the correct treatment and to avoid incorrect diagnoses and therefore incorrect treatment. That may be overly simplistic, but from my perspective, I see so many people who've been given incomplete, incorrect advice. So that's kind of how I frame this conversation, very, very high level. How do you think about this?
Yeah, I think it's interesting because hypothyroidism is quite straightforward to make the diagnosis. We have a very good method, a biochemical method, which is measuring serum TSH. And for most patients, serum TSH is the perfect tool to make the diagnosis of hypothyroidism. Of course, there are patients in which we cannot use TSH. Those are patients with central hypothyroidism. But those are, we're talking about 1% of the number of hypothyroid patients.
Right.
Even though it's a small percentage, if you think that we have 20 million patients with hypothyroidism, 1% turns out to be a significant number. So I think we should always keep in the back of our mind that people with central hypothyroidism exist, and we can't trust the TSH for those individuals. But that's a rare condition. Let's say we can't trust the TSH, okay? So it used to be that you need to have a high TSH, and then I'll make the diagnosis of hypothyroidism. Now, over time, that high TSH, how high is high, is coming down. The threshold for me to say, well, you do have hypothyroidism is coming down. It used to be greater than 10. Right. Now, however, the upper limit of normal is 4.5, and there's a gray zone between 4.5 and 10. And what do we do with those individuals? And that is something that's called subclinical hypothyroidism, because patients are supposed to have only minimal symptoms. But I think it has to be decided on a case-by-case basis. And so I do believe that it's not that complicated. It's just that we as you said, we need to look at what's in the literature, what people have done, and because sometimes it's really not beneficial to go with treatment. And in other cases, it is beneficial for two patients that have the same TSH value.
Right. Well, I really appreciate your perspective, and I can tell that it's really evidence guided, because many of these things are the exact conversations we've had on the podcast in the past, which is diagnosing hypothyroidism is actually pretty straightforward. And this is where I think conventional medicine is doing more right than it is wrong, because sometimes I think any camp of thought in alternative medicine will have some things incorrect, some things correct, and conventional medicine vice versa. Nobody is correct on everything all the time, but I've often said on the show in the past that as far as I can tell from a fairly careful examination of the data, conventional medicine is getting this much more right than they are wrong. And it is pretty clear cut and straightforward. And I do want to dig into some of the nuances that people are probably struggling with. I don't feel well. I go to see a healthcare provider. Let's say I go to see my endocrinologist. They say I don't have hypothyroidism. Then I go see an integrative medical doctor or some other sort of functional doctor, and they say, oh no, I do have hypothyroidism. So I want to come back and really give people the straight talk on that. Hey guys, okay, I wanted just to insert this here because we get a little bit on a tangent regarding prevalence. So more to follow on prevalence, actually quite important information and a few updates regarding prevalence given our discussion. But so as to make sure we don't lose the important objective of giving you the diagnostic criteria straight talk, here they are. Really two ways of diagnosing hypothyroidism. A high TSH, defined as above 4.5, which is the cutoff for LabCorp, Quest, all your big box conventional labs. So a TSH of 4.5 or higher, paired with a low free T4, and the free T4 range is between 0.8 and 1.8, again, at your big box labs, LabCorp, Quest. So that's one, a high TSH paired with a low free T4. Very important, according to the conventional lab ranges, not what your doctor may alter and use sort of these different, more contemporary ranges, which are not correct. So that's one. Two is where you actually have normal free T4, but you have just an elevated TSH. And this is where I think people get into the most trouble, because as this diagram articulates, again, this is when looking at solely elevated TSH. So the free T4 is normal. When your TSH goes above 4.5, you are what's known as subclinical hypothyroid. So you could be 5, you could be 5.5, you could be 6, you could be 7. You really don't get into a position where you'll benefit from thyroid hormone, where you're considered hypothyroid, until your TSH gets somewhere above 7 to 10. So that's this transitional zone. And we have pretty compelling data that have answered this question. People in this subclinical range do not seem to have problems. They don't have more symptoms, and they certainly do not seem to benefit from thyroid hormone replacement therapy. However, when people get past this transitional zone of 7 to 10 and they're above 10, maybe above 7, when they're in this range, this is where people seem to benefit from thyroid hormone. So why this is so relevant is there are a lot of people, it appears, being given hormone when their TSH is subclinically elevated, subclinical hypothyroid, and these people do not benefit from treatment. And sadly, they oftentimes start on lifelong thyroid hormone replacement therapy. So bear this in mind, very, very important. Now, I also wanted to mention that we do have a course we've developed to help you with this. And part of the reason why I'm so proud of this course is, as you may know, we published 2 papers on the gut-thyroid connection and more broadly articulating how the misdiagnosis of hypothyroidism is quite rampant and sadly leads people to have subpar care. And this is the course homepage along with the 2 papers that we published. So in addition to Dr. Bianco's book, which I would recommend, obviously because he really knows his stuff and I was impressed with his degree of knowledge, we have a course here that really puts all this together. And how I think this will complement Bianco's book is we go a bit deeper into dietary, lifestyle, and supplemental interventions like selenium ionositol, amongst others, for improving your thyroid health. And perhaps most importantly, we integrate in this algorithm of how and when do you integrate gut health interventions so as to treat the true cause of your symptoms and not get sidetracked into perhaps treating subclinical hypothyroidism and leading yourself to sort of flounder, which is what in this paper we chronicled with a 6-part case series of how important it was to really get to the bottom of the symptoms and not just assume the symptoms were thyroid in nature. So anyway, some resources available for you, and wanted to make sure to insert the diagnostic criteria. Let's frame this with prevalence, because one of the things that's been upsetting to me is some of the thyroid gurus will have messaging that would make you think 20, 40, 50% of the population maybe has hypothyroidism. And as we've looked at the literature, NHANES data is clocking in about 0.27. So we say 0.3 to make it an easy round number for people. So, I mean, that is a subset of the population, clearly, and it's not to sweep that under the rug because it's not 15%, let's say, like IBS is. But can you speak to that? Because I think people are being confronted with mismessaging regarding how prevalent true hypothyroidism actually is.
Okay, so I think I got it. So it is important for us to know what is hypothyroidism, because many patients come and say, well, I have hypothyroidism, but the tests are normal. TSH is normal, free T4 is normal, right. T3 is normal. Who gave that impression? The presence of positive TPO antibodies.
Yes.
So many patients have positive TPO antibodies and they say, well, I have hypothyroidism, I need to be treated. And we know that that does not trigger treatment. That just tells us that the patient has in their blood antibodies against the thyroid. So they could develop hypothyroidism in the future. They could never develop hypothyroidism. They could be positive for the rest of their lives and the thyroid be working well. So it's really hard to predict. I think that with those patients, what we do is every 6 months, we check TSH to see if there's a progression, having said that, if you're talking about the prevalence of hypothyroidism, I think the NHANES data and a lot of other data suggest that it's around 5% of the population, overt hypothyroidism. So that would give us about 15 million individuals in the United States that have overt hypothyroidism, meaning that they need to be treated with levothyroxine. Now, there's a recent study showing that there are about many millions, of maybe 10 millions, that have subclinical hypothyroidism and are being treated with levothyroxine. And that we could discuss that. But in general, the number that we see from different fairs, from different databases, is about 5% of the population.
No, let's dig into that, because this was something that I used to think, and let me know if I've misinterpreted any of the data here, because I care mostly about having my facts straight.
Sure.
But when we looked further, we saw that many of these papers were calling both subclinical and true hypothyroidism as hypothyroid.
Correct.
But when you break them out, it's more like 4% ish are subclinical, and maybe 0.3, 0.5 are frank or true hypothyroid. Do you agree with that general finding?
No, I think, no, I think it's about 4 to 5 overt, really true hypothyroidism. And we have about 4 to 5 of subclinical hypothyroidism. So this was just published, a study 6 months ago.
So this is a recent finding. So this is not coming back to the NHANES.
These numbers have been around, and I don't think they have fluctuated much. I think it's 4.5 to 5% of real overt hypothyroidism. It has been like that for a long time.
Okay, so let's do this then. If you don't mind, I'll send you a follow-up email with just a quick snippet of my data, my rationale. You can send me yours, and then what I'll do is I'll record a B-roll post, and I'll put it up here for people. That way we can. Okay, great.
Absolutely.
So somewhere in either a little less than 1% my claim, 4 to 5% your claim, but it's still, I think, in the same realm of prevalence, wherein we shouldn't be telling people, well, it's maybe a 50% likelihood that if you have fatigue and dry skin, you have hypothyroid.
No, absolutely right. No, I agree with you. This is, it's not, that's wrong.
Okay. So I had a really productive email exchange with Dr. Bianco, and here is what we found. And this is quite helpful, actually. And I really just appreciate his commitment to the truth and his data-driven perspective. So again, framing the argument, I was making the claim that the prevalence is about 0.3% for true hypothyroidism. Now, it does depend on what NHANES data set you look at, right? But they've averaged anywhere from about 0.2 to about 0.3. So this is the most recent, or at least from our examination of the data, NHANES, 2007, 2012, sample size of about 10,000 people. And this is just a screenshot from the NHANES data. What could be a little bit misleading about that potentially is subclinical and clinical or frank or overt hypothyroidism are often lumped together. So they would say 3.7, combining the 3.5 plus the 0.2. So according to this NHANES data set, they found about a 0.2 prevalence of true hypothyroidism and about a 3.5% prevalence of subclinical, or sometimes labeled sluggish, thyroid. Here's what I really appreciated about the exchange with Bianco, and something that he helped me to see and better appreciate. He's referencing a paper from the Journal of Endocrinology, or the Journal of the Endocrine Society. They looked at a more recent snippet of NHANES. This is the National Health and Nutrition Examination Survey. So population screening includes physical examination, lab testing, questionnaires. So there's a more recent data set, 2009 to 2012. But here's the key thing. They combined with this insurance data on people who are on prescription thyroid hormone. They also relaxed some of the diagnostic criteria. So their sample size became a lot larger because of this, 255 million. Part of the reason why the sample size is so much larger as compared to the other NHANES, the 10,000. This group included thyroid antibodies. So the more lab markers you include in your analysis, the less people you'll have in your sample, because the less people are going to be doing a more rigorous or a broader panel, right? So this data set, earlier NHANES, included only those with thyroid function, TSH, T4, plus TPO antibodies. The more recent NHANES looked at people who only had TSH and T4. So that increased the sample size, as did the inclusion of non-NHANES data from insurance. Okay, but here's what's important. they found a 2.1% prevalence of overt hypothyroidism. That's an order of magnitude higher. So this is really important to mention. And this is where, dare I say it, we were wrong, or perhaps more better stated, we had not yet come across this data. This was published last year and we just hadn't seen it yet. So big credit to him for flagging this. So this takes my estimation from about 0.3 at least to 2.1. Now, they had also looked at, from this graph here, 6.1% of people who are on thyroid hormone. Now, how we interpret this is really important. So they included anyone on prescription, including those with overt hypothyroidism, those with subclinical, those who are only on T3, let's say for weight loss, and those who may have been misdiagnosed. And we've discussed this paper in the past, this meta-analysis that found that 37% of people on thyroid hormone could come off of it, maintain normal blood levels of thyroid hormone, and have no change in their symptoms. So because of that, and because this is a little bit loose of a grouping, I cut this number in half. And here's my math, right? So the updated hypothyroid prevalence kind of give you the bottom line first. 2.1 based upon labs. This is the overt here, all right, verifiable hypothyroid. And then from this graph, 6.1% that might be hypothyroid here, right? And we talked about this is anyone on medication, but because we know some people are incorrectly on medication, and when you include those who are just on T3, perhaps for weight loss or just as a sort of Hail Mary last-ditch attempt to try to improve someone's energy or other symptoms, I think it's reasonable to cut that 6.1 number in half to account for those on medication who don't need to be. So if we take the 2.1 plus the 3, this gives us the updated number that I think is probably conservative, but accurate, of 5%. So to update my position on this from the 0.3% of the population being true hypothyroid to about 5, this is a big shift. This is a significant shift. Now, that being said, as I mentioned just before cutting in from the clip of the interview here, this is still far from what I think what some thyroid thought leaders would have you believe, that there's a 50% likelihood or hypothyroidism is vastly underdiagnosed. 5% is something, certainly should not sweep that under the rug, but looking at IBS, 15% of the population has IBS. So there's still 3 times more gastrointestinal issues than there are thyroid issues. So again, just wanted to share this. My initial position was about 0.3% looking at earlier NHANES data. Bianco cites an excellent paper from the Journal of Endocrinology, the Journal of the Endocrine Society, looking at more recent NHANES. It's a larger sample size because it has relaxed inclusion criteria and also includes insurance data. Now they have this breakdown. 2.1% is overt, 6.1% were on medication, but probably only half of those people are true hypothyroid. So again, if we add the 2.1 plus half of the 6%, so 3, so 2.1 plus 3 is 5. So I think we can update to a more accurate, contemporary, and reasonable estimation that about 5% of the population is truly hypothyroid. And again, I really appreciate Dr. Bianco's being on top of the data here. A very important update. Wanted to make sure to share it with you guys. The other thing that you said that I also have discussed in the podcast in the past, I feel is really important to highlight, is this paper by Levadas. This is going back maybe to 2019, where they were looking at this and what they called ambiguous hypothyroid diagnosis. And they found about 61% of patients who are on hormone could stop the hormone and maintain normal TSH and had no regression of their symptoms. It was followed up by a meta.
Yeah, no, I know the
Well,
study.
then the meta-analysis from maybe a year later found about 37.1%
That's
of people
correct. Yeah,
could stop their medication. So there's a decent subset of people probably watching this. If that meta-analysis is correct, maybe 1 in 3 who are viewing this might be on a hormone that they don't need.
right. And it's just crazy. And this is exactly what I was mentioning earlier. Patient comes to the doctor, has a TSH that is 5, has symptoms, and the doctor, without further investigation, will just start that patient on levothyroxine. And
Right.
the patient is going to be labeled hypothyroid for the rest of their lives. And
Yes.
they will blame everything that's wrong with them to the hypothyroidism that, in fact,
Yes.
they might not have. So that
Yes.
I think that's really important. And so in my practice, I would say that I would take patients off levothyroxine because you need to be certain of the diagnosis before you treat someone with the specific medication. So if you're not certain, if a patient cannot show me an elevated TSH that I can convince myself that patient has hypothyroidism, is really hard to continue without further investigation.
This is a crucially important point that you make. And we're
Yes.
seeing the same exact thing. And so now even in our paperwork, we ask a few questions. How was your hypothyroidism diagnosed? Was it diagnosed by a conventional provider who was kind of conventional practice, or was it more integrative, anti-aging, functional? And then we'll pair that with, do you have a family history? Right? Family history suggestive. And what was your TSH at time of diagnosis? If you don't know, see if you can find it. And it's a pretty short list. Again, straightforward, like you said a moment ago. If it was diagnosed by an unconventional provider, it throws up a flag for me. If there's no family history, throws up another flag. And then the most important thing is at the time of diagnosis, their TSH might have been a 3.9 and their T4 might have been, let's say, 2 at the lower end of normal, but still within the normal range. But the provider says, oh, there's these new values that are more narrowed.
Oh, yeah.
Those are the ones we have to follow. Now you're hypothyroid. And the real travesty, yes. And then the real travesty is this person brings that diagnosis forward to other doctors and no one thinks to question it.
Exactly right. And what I've seen doctors do in many cases is lifting the results from the clinical lab into their own letterhead with different reference range. So in the clinical lab, you have a broad reference range, which is the well accepted. But when they print on their letterhead, they give a much stricter reference range. And in that reference range, the patient has hypothyroidism. I've seen that happen, which is, for me, I don't even know how to qualify that.
Okay, and just to insert this here, hypothyroid, again, is high TSH paired with low free T4, and subclinical or sluggish thyroid is high TSH with normal free T4. And the ranges are 0.5 to 4.5. Some labs are now using 0.4 to 4, but I mean, it's really a minimal difference. And free T4 is 0.8 to 1.8. The devil's advocate position here, I think, is a person is suffering. The doctor is trying to help them. They've probably learned this from a book or a seminar from a thought leader who I would assume is well-intentioned. And perhaps that hypothesis 5-10 years ago, being very charitable, you could have gotten on board with. But there's enough data now to where we have a really clear answer on this question, because we've done the studies of the scientific community, that is, taking people with subclinical hypothyroidism, meaning a TSH that's over 5, right? So also called sluggish thyroid,
right?
And they've been given hormone, and fairly consistently, they do not show benefit, which is why I think, to your point, it's so important that we get someone on the right track, because we don't want them incorrectly thinking that they're hypothyroid, and then, to your point, blaming all of their symptoms on thyroid. Oh, I'm having brain fog now. I got to go back to the doctor and try more T3. And they get on this merry-go-round where they never see consistent results.
That's exactly right. So I think that one of the points that, let's say a patient that has a TSH of 6, should we treat or not? So I think that first, how old is the patient? As we know, the older you get, you're going to have it's expected to, you would tolerate higher levels of TSH.
Right.
That's number one.
A drift, age-associated
Right.
drift. Yep.
And a rule of thumb is for every 10 years of your age, you increase by 1 point the upper limit of normal TSH. So someone that has 60, we will tolerate up to 6. Someone that is 70, we will tolerate up to 7.
I like that.
The other thing is, does this patient have positive TPO antibodies? That's also an indication. Well, there's an active process. There's no active process. That will for me will make me inclined to treat that patient, the positive antibody, with a TSH high of 6 or 7. Second thing is, I would ask for a thyroid ultrasound, because if there's a destruction going on, there's a patchy appearance of the thyroid gland. The gland doesn't look normal. So I would put all this information, family history, as you mentioned, symptoms, all of this, and say, probably we should try to give thyroid hormone and see if it's going to be better. Because if everything else is negative, it's just the TSH, I don't think we should start a treatment. I would try to explain that to the patient so that the patient doesn't get frustrated. Because I had many patients rushing out of my office saying, this doctor doesn't understand, because it's clearly I have a problem and he doesn't want to give me treatment.
Right. Well, maybe something to sort of reinforce your position. We published a 6-patient case series in the IMCJ last year of people who probably left an office like yours, where they were getting the right advice, floundered in Thyroidville for 6 months to 2 years, came to our clinic, and we found that there were other factors present driving the symptoms, oftentimes digestive in nature, not exclusively. And I know you discussed this. I want to come back to that in more, full in a moment, but I did want to linger on the antibodies for a moment, because this is another tripwire I see for patients, where they assume that autoimmunity or thyroid antibodies equates to hypothyroidism. And
Correct.
I'm so glad that you raised that point. When you look at the data, sometimes I feel like I'm taking crazy pills, because I look at the data, the stats, and I say, so how are these data leading to those thought leader conclusions? And you'll look at something like roughly 15% of the population has positive TPO antibodies, but we don't see that same level of hypothyroidism. There's a disparity, meaning that I would say the minority, less than 50% of people with Hashimoto's or autoimmunity become hypothyroid. And in fact, it's probably far less than that. And so it's empowering to the patient, because that means the antibodies are something you can watch. You can clean up your diet, maybe use vitamin D, selenium, ionositol, but not think that that is a sentence of becoming hypothyroid.
Absolutely. That's not how you make the diagnosis.
Right. And then the other point that I'm curious to get your thoughts on it, and see if you've dug any more deeply into this than I have, but we've seen roughly 15% of the population with Hashimoto's, as confirmed by ultrasound, about 5%. Are you finding that same? So telling you that you can have the antibodies but not have any appreciable damage in the thyroid gland.
But that's perfectly fine.
What have you seen there?
I don't have the numbers, but what I know is having the antibodies, there's plenty of patients with positive antibodies without damage of the thyroid gland. Absolutely.
Right. Are you looking at a certain value for TPO? I think the data here are early, but based upon the best data that we have, we've come up with a cutoff point of 500. If someone's TPO antibodies are above 500, and this is what one study found, if they were above 500, there was a moderate risk of development of hypothyroidism in the future. If they were below 500, there was a minimal or almost non-existent risk. And so we've used this to help patients look at TPO a little bit more similar to blood glucose. If you're 101 for a fasting glucose, we'll watch it, but I'm not going to be up in arms concerned. If you're 170 with blood glucose, then we'll take some action. So we're looking at TPO in a similar vein. Do you have any thoughts in that regard?
Yes, I don't give a lot of value to the absolute value of TPO, because first, the numbers fluctuate a lot. One day the patient can have 500. The very same patient the next day might be 600 or maybe 400. So for me to know exactly what's going on, I would just ask for repeated measurements. But you're right. There are patients that have very high titer of TPO antibodies. Those are most likely to have a destruction going on, and those that have very low titer. For me, I don't look at that as a diagnostic. I'll just say if you have TPO positive, I would just keep an eye on that. I would either,
Right.
if it's me that's following the patient or if it's a primary care physician, I would just check the TSH and free T4 every 6 months, more frequently than I would check for another patient.
Right. Yeah, seems very practical. So let's come to this question of, okay, my thyroid labs are normal, but I still have symptoms. And just to your point also, thyroid labs are normal according to LabCorp or Quest, not what your healthcare provider wrote in,
Correct.
or not what some intermediary interpretation software is using.
Yes.
Conventional ranges, so TSH is not above 4.5 or 5, and the free T4 is 0.8 to 1.8. Labs are normal, but I still have symptoms. I know you've published on the importance, and there's a lot of data on this, of ruling out other causative factors.
Correct. Yes.
Gastrointestinal, like we've seen a lot of H. pylori, IBS, celiac, anemias, sleep apnea, female
Iron
hormone
deficiency,
imbalances.
yes, obesity, diabetes, any chronic condition will cause symptoms, in my experience. And I have to say, this will depend on the specialty, depends on the practice, depends on the area. In my experience, the most relevant confounding factor is menopausal syndrome, because you cannot tell the difference between perimenopausal symptoms and hypothyroidism. The skin gets dry, you're gaining weight, the hair is falling, constipation, low energy, memory is failing. The symptoms are very, very similar. So I start by measuring FSH. Let's see what is the status of how's the ovary functioning. And from that point on, I'll just go, as you mentioned, iron deficiency, anemia, vitamin B deficiency, all sorts of other autoimmune diseases that we know are prevalent in patients that have already one autoimmune deficiency. It's more likely to have a second one. So I think that most of the time we end up finding a reason for those symptoms.
It's funny because our clinical observations are just incredibly similar.
Yeah.
And this is one of the things our clinical team in our paperwork is looking for. We have a list of female hormone symptoms. And so what you may see, their chief complaint is dry skin, depression, and fatigue.
Right.
And they don't mention their cycles are irregular. Maybe they have heavy periods when they do cycle, and they're having hot flashing. And so when you put those together, now you're saying, well, it's probably not hypothyroid. It's probably your female hormones.
Absolutely.
And yeah, it's been alarming how many people have been kind of shoehorned into thyroid when it really seemed to be their female hormones implicated.
That's right.
Yeah, it's a great point. Okay, so for our audience, these are all things that you want to keep in mind. If you're being told you have hypothyroidism, you may want to seek a second opinion depending on the constitution of the provider that you're working with. And again, I think everyone's doing their best, but the education and the system here, I think, needs to be updated. And not every doctor has kind of gotten on the other side of these updates.
Right.
One other thing that I was thinking about before our conversation today is I look at T3 as a metabolic and inflammatory indicator, just using sort of a loose label, not really or not at all being diagnostic of hypothyroidism, but telling us about metabolism and about inflammation. And sadly, some patients are told, well, your TSH is normal, your T4 is normal, but your T3 is low, hypothyroid. And that couldn't be more incorrect, in my opinion.
That's correct. I totally agree with you. T3, so this is interesting because I value T3 so much. However, it's not to make the diagnosis of hypothyroidism. It's to monitor the treatment of hypothyroidism. Those are two very different things.
Yes.
Now, to make the diagnosis, I always receive patients have, as you described, has a normal TSH, normal free T4, and the T3 is low. Why is that? So we find that obviously there's the low T3 syndrome. If you're sick, if you're ill, you might have that picture. So if you go into a general hospital, as you know, many patients that are admitted will have a low T3 syndrome, which is what we just talked about. Now,
Right.
if this is a patient in the outpatient clinic, I find it a caloric restriction is a very important factor that will lower T3 levels,
Yeah.
especially if you're cutting carbohydrates. We know that T3 levels in the circulation correlate with two things. First, with caloric intake, and more specifically, with the content of carbohydrates of your caloric intake. So if you're in a diet, you're trying to lose weight, you cut your caloric intake, cut carbohydrates, go to protein-enriched diet, your T3 is going to go down.
Right.
So I think that's expected. That's how the body will react to when you're cutting calories.
And to piggyback on this, then that person may be saying, well, I'm not losing enough weight. They go to a doctor, they get a test, and they go, oh, it's because you're hypothyroid. And
that's exactly right.
And it's really a misinterpretation of how this works. Yeah.
Yes, it is pure thyroid physiology that many of these doctors don't quite understand. I mean, it's hard to say, but that's the truth.
And with us seeing a large cohort of IBS patients, it's restriction for a different reason. What flares? My diarrhea, my constipation, my bloating, my pain. But it's the same thing. So, and then they'll think, well, it must be the hypothyroid that's leading to my constipation and my low mood and my poor sleep. And we look at that as you're probably too restrictive. You're hypocaloric. You're under carb, fed. And that's really what we have to do rather than putting you on lifelong thyroid hormone.
Absolutely right. Absolutely right. I mean, I totally agree. Now, when a patient with no other complicating factor was diagnosed with hypothyroidism, and we treat that patient with levothyroxine, as you know, many patients do very well on levothyroxine. Most patients, I mean, probably 80-90% of the patients with hypothyroidism do well on levothyroxine. But for some patients, that's not quite true, as we might eventually talk about it. But if you look at T3 levels in patients that are being treated with levothyroxine, the T3 levels are always the bottom of the normal range. And in many patients, it's below the normal range. So I think that is something we want to keep in mind. Why? Because T3 is the active hormone. T3 is the thyroid hormone. It's not T4. T3 is the one. So if you're treating someone, you're normalizing TSH with levothyroxine, but you're not bringing T3 to where it should be, that is probably an issue. And this is something we are actively looking, and not only us, but the many groups in the world are looking at why do these patients maintain a low T3 despite having a normal TSH, despite receiving levothyroxine, and whether or not for those patients would be good to give additional T3 so that we can bring them up to the normal range.
And this is one of the things I found so refreshing about your work. It tends to be people are on either end of the spectrum. Only T4, anything else is quackery, or you must start with combination therapy. And if you don't, you're doing a disservice to your patients. And very few people seem to be sort of echoing what the research finds, which is T4 is probably the best starting point. You should not start with combination therapy, then reevaluate. And for a subset, they may be best positioned to then do the combination therapy.
I would totally agree with that, because just think about it. If you assume that we have 15 million patients with hypothyroidism, can you imagine how many endocrinologists you would need to see all these 15 million patients? We don't see those patients. Other doctors, primary care physicians, gynecologists, geriatrics, I mean, all sorts of other specialties are seen. Why? Because they do very well on levothyroxine. We tend to see those patients, the minority of the patients that remain symptomatic despite normalization of TSH. So we are a little bit biased for that population, but in reality, levothyroxine is an excellent starting point for treatment of hypothyroidism, and most likely than not, that patient is going to be feeling well just with levothyroxine for the rest of their lives.
Right. And that's essentially what we published in that 6-part case series where, and big credit to Dr. Joe Mather, one of his case studies was a beautiful sort of portrayal of the arc where he went from just levo to levo, I think, plus cytomel, then to a desiccated, and tried all these different treatments, came back to, well, let's do just levo and let's support your gut health. And then the person felt better. So it's not to say it has to be all one or all the other, but looking at this in sort of a hierarchy, the first thing would be levothyroxine. And this begs a question that I think you have published as a thought somewhere. Should patients be starting with combination therapy? And I believe your perspective on this is no. And we kind of have been alluding to all the reasons why, but anything else there that you want to share with people from the perspective of, we hear you, we're listening, we want the best for you, we're open-minded. It doesn't mean that everyone should start on combination therapy.
Correct. I would agree with that. I mean, I think that we want to resolve the problem for the patient. The patient wants to feel healthier, better.
Right.
And for most patients, levothyroxine will do that. We're going to fix the problem and the patient's going to feel okay. He's going to feel better. I think that end is going to go home and is going to forget that it has hypothyroidism. So if that's so simple, that should be the first approach. Now, if that patient remains symptomatic despite treatment, then we start investigating. And then if we exclude other reasons, like, gut problems, all the things we talked about, then you can give it a try to combination therapy. Some patients like synthetic combination therapy, which is giving levothyroxine plus liothyronine. Some patients prefer desiccated thyroid extract. When I went to medical school and I did my training, desiccated thyroid extract, first of all, I had no idea what that was. It was, at some point, I think I read somewhere, they said, no, don't absolutely use that because that's crazy, that's old. So as it turns out, there are 1.5 million people in the United States using desiccated thyroid extract. Many more than those patients that are using combination therapy with synthetic levothyroxine and liothyronine. I don't quite understand why. I think there are a couple of reasons that I can envision. First is some folks are connected with the idea that, oh, this is a natural thing, so it's better for me. In fact, I don't buy that. I think that both drugs contain T4 and T3, so it's if you're taking a natural from the pig's thyroid, or if you take synthetic, it's basically the same. The other thing is, what I can imagine is co-payment. Many patients will, if you have to take levothyroxine and liothyronine, you're going to pay two co-payments as opposed to one. So it's quite curious why patients prefer that, or many patients. But I think these two reasons would explain that. In my view, they're both equivalent. There's no one better than the other.
Right. And I think I can partially speak to that as a naturally sort of leaning provider. I look to things that are closer to nature first rather than synthetic as a rough heuristic, but there are absolutely exceptions to that. And I think it's good for our audience who is probably largely more in the camp of trying to do things naturally and as minimally invasive as possible to understand that's maybe a starting point, but there are going to be exceptions to that rule.
Yeah, absolutely. I mean, it used to be in the past, the patient would come and say, oh, I'm taking desiccated thyroid extract. It's like, let's change that. Completely wrong. Let's change that. I learned. I know better now. But first of all, I could never take anyone off desiccated thyroid extract. Believe it or not, I tried, I talked. They say, no, I'm okay with this. I just want to refill. I don't want to change this. So, and I learned that was, in fact, we published a few papers on desiccated thyroid extract. It's perfectly fine to be treated with desiccated thyroid extract. I would give preference. I would give credit to the preference of the patient, because these patients, as you know, they feel that the doctors are not listening to them.
Right.
And by listening to what makes them feel better, it's something that, that you create a relationship with your patient.
Right. Exactly. And to your credit, you being more in the conventional camp and your early training suggesting you should never use desiccated, you were able to learn your way to be more open-minded and actually do research on the use of desiccated,
Yes,
right? So, a commendation to you for being open-minded. And I think if we are open-minded, no matter where we start, we're going to find our way progressively more toward where the truth or where the optimal is.
absolutely.
And just one point I wanted to make, because I do want to come to thoughts about combination or desiccated, some of your research therein. But as I've been thinking more and more about how do we communicate with patients about the use of just T4, levothyroxine, let's say, the way I've been thinking about it is, first, let's try giving your body the upstream hormone and let your body dictate how it wants to metabolize it downstream to T3. So let your body be more so in charge. That's just my philosophy, but anything there that you would agree with, disagree with, or
No,
how else do you think
that's
about
perfect. That's exactly how I would phrase it. I mean, this is a pro-hormone. This is something your body's going to take it and process when it needs it and how much it needs it. And I think that works for most patients.
Right, right. And then, to some of your research there, and this is something that I've shifted my opinion on slightly, which is to also become more open-minded to combination therapy. I was never fully against it, but the challenge I was in is being in a field where the default de facto position is everyone on combination therapy, they've got to be. And that's quite discordant with the data. But as the data set has been evolving, there's the one trial that you published in 2021 in clinical endocrinology, and metabolism, where you found that there was a preference for combination therapy as compared to levothyroxine,
Right.
but in a cohort that first didn't fully respond to the T4 alone.
Exactly. I think that is the critical piece of information.
Right.
If the patient is doing well on levothyroxine, unlikely that patient is going to do even better on combination therapy. There's no reason. We know both treatments are equivalent. Now, we should focus on those patients that are not doing well on levothyroxine. And for those patients, combination therapy is a good option after you eliminated other causes of not feeling well. And this is not something we invented. This is something that has been already in use in Europe for a number of years.
Right.
In 2012, so 11 years ago, it's going to be 12 years, the European Thyroid Association already published guidelines saying that if the patient does well on levothyroxine, don't touch it. If they don't do well, then you start investigating, and combination therapy might help.
Right.
And let's not treat everyone with combination therapy. At this point, I'm totally against that.
Right, right. So then to maybe put this into a hierarchy for people, first thing, do your blood test. And if you are hypothyroid, and that's not always as easy as it sounds, but
right.
First thing, get a competent provider to read your blood labs, get a diagnosis. Second step, levothyroxine. If you're not fully responding, then look for other factors, female hormones, metabolic imbalances, inflammation. And then the third and final step is consider a trial on combination therapy.
Correct. I totally agree with that logic.
And so for our audience, that, if you follow that framework, you should save yourself a lot of strife, wheel spinning, and poking and prodding with all these different adjustments of your hormone that should get you the most improvement in the least amount of time.
Now, I mean, it's a challenge for the audience. I mean, if your audience is made of patients, to find a doctor that's going to follow that algorithm, right? Because as you said, many doctors are just levothyroxine and that's it. Other doctors are just combination therapy. So what I tell patients that look for me is you need to find a doctor that matches what the thinking that you think it's correct, that you agree with. For example, a simple thing, if the doctor doesn't have time to talk to you, if those doctors that are going to see you in 10, 15 minutes, change doctors, because this is not the disease you're going to resolve in a 10-minute consultation. That's number one. Number two, check with your doctors. How amenable are you for combination therapy? If the doctor says don't even waste your time going to see the doctor. I mean, I think that patients need to do some homework and find the doctor, the provider that match their state of mind.
Right. And I'll add to that. Be on the lookout for providers who are overly confident, very assured, right? If you hear any absolutes, everyone must avoid gluten, everyone must supplement with vitamin D, everyone must be on T4 or combination or desiccated.
Right.
Those are usually indicators that your provider is not open-minded.
Correct. Yes, I agree with you.
Now, what about a liquid T4? So for our audience, T4 comes in a levothyroxine in a tablet, but there's a different type of formula, oftentimes trade naming as Tyrosint. That's just one example. It's a liquid gel tab. And for people with impaired gastrointestinal absorption, let's say maybe ulcers, H. pylori, and these have been studied, the switch to a liquid gel tab, T4, rectifies their TSH levels, improves their symptoms. Now, I think ideally you want to resolve the gastrointestinal issue, but for some people, maybe they have inflammatory bowel disease and they're doing the best they can, but it might be several months until they get that fully sorted out. So in the meantime, a form of the hormone that's better able to be absorbed can be a win for people. I don't think this gets a ton of press, but what's your experience here?
So my experience with this formulation has been almost exclusively on patients that complain of allergic or adverse reaction to levothyroxine. Some patients say, well, I start taking the tablets, I have rash, I have itching, I have, and it turns out the patient has, it's not allergy, but it's a reaction, intolerance.
Kind of hypersensitive. Yeah.
Yes,
yeah.
hypersensitive to the dye in the tablet. So levothyroxine formulations, they come in colors. So some of those colors can cause intolerance. And so what I do is I change to something that is without a dye. That will be my first approach. Change to a tablet that doesn't have dye. If that doesn't resolve, then I go to the gel cap, because that has basically the levothyroxine is in a solution with glycerol, and there's no other excipient. It's just glycerol.
Right.
So,
right.
And many patients that I had resolved any symptoms because all those excipients and dyes and everything are gone. Now, you're absolutely right. There are studies being published showing that patients that have GI issues, the pH is not right, or other inflammatory issues, they absorb better with these gels. I don't have that experience in my own practice, but colleagues have and have published as you described.
Right. And they bring that back to sort of a hierarchy for the audience. Ideally, resolve the GI issue, but also being practical and not overly idealistic. For some people, they're struggling. They may not have competent GI, care, and so at least in the short term, that might be an easy win for people with the liquid.
I would agree with that.
So something else that I don't think we can make a super strong scientific case for is there being any harm conferred by the use of T3 along with the T4. I do see some individuals who they seem to get more sped up when they have the T3 in combination as compared to just the T4 alone. Heart palpitations, anxiousness, insomnia, sweaty palms. Doesn't happen a ton of the time, but for some people, it seems a pretty clear indicator that their body does not want the T3 and their body wants to be able to take the T4 and metabolize as it sees fit. There was one study that found increased cardiovascular events in those who were using the T3, but there was a larger study that didn't find any ill effects. What's your thinking on, should we be a little, for the people who think it's got to be combination therapy, including T3 all the time, is there maybe a double edge to that sword?
Okay, awesome. Let's talk about that. So how do you start combination therapy? You take a patient that has a normal TSH taking levothyroxine. normal TSH, taking levothyroxine. And to start combination therapy, we are not going to add T3. We are going to reduce the dose of levothyroxine and add T3. Because if you just add T3, the patient is going to become thyrotoxic, right? Because if you're giving 100 mics of levothyroxine and the TSH is normal, if you add 10 micrograms of liothyronine, you're going to suppress the TSH, and the patient is going to be jittery, as you described, palpitations, right, sweaty, jittery, and we don't want that. That's not the idea at all. The idea is not cause thyrotoxicosis. The idea is to replace lower T4 and give T3 with maintaining a normal TSH, a detectable TSH within the normal range. If you do that, it's unlikely that you're going to see a side effect or adverse reactions. The study you mentioned was made in Korea, and they don't have TSH, they don't have T4, they don't have T3. So I don't know how much they were taking. I don't know how they were doing. So in other studies in which we carefully measure TSH, T4, and T3, and we preserve that within the normal range, in fact, there are 20 clinical trials showing that the combination therapy caused the same number of adverse reactions as levothyroxine alone.
Yeah.
20
this is a great point.
Yes. So I think that it's really important not just to add T3 to whatever you're taking. No, we have to reduce the levothyroxine. Otherwise, patients will become thyrotoxic. And of course, thyrotoxicosis causes bad outcomes: atrial fibrillation, osteoporosis, anxiety, a lot of stuff.
And even fatigue in some people, which I think is underappreciated.
Absolutely, yeah.
And
muscle wasting, yes.
Yeah, and I'm sure you've seen similar where the healthcare provider, again, always assuming is well-intentioned, but they've been educated that we're targeting the upper half or upper fourth of T4 and of T3. And someone comes in and they're either at the upper end of the range or they're elevated for T4 or T3 or both, and TSH is suppressed, and the patient's saying, I'm not feeling good, I'm developing osteoporosis, I'm not sleeping well. And it's like, holy smokes, you're just trying to juice the thyroid system, and you're totally discarding this really important concept, which I call the Goldilocks zone, right? The bell curve. We want to be in that appropriate zone biologically. Too much, not enough is where outcomes are poor.
Yes, I agree. And unfortunately, there are many doctors that disregard TSH and will just blast thyroid hormone, and in order to make the patient feel better, but ignoring the fact that we are creating a condition that's called thyrotoxicosis.
Yeah. And again, just to echo for people, because I think fatigue and depression might be two of the biggest complaints I think at least the patients I work with suffer with. And you can make that worse with too much thyroid hormone. This is why Graves patients, ironically, are sometimes tired.
Exactly.
And Graves being a condition of hyperthyroidism.
That's exactly right.
Yeah. Well, I think we've gone through a lot. I mean, this has been honestly a conversation that makes me feel like I'm less insane, because oftentimes I look at what's going on in the thyroid field and I feel like an island unto myself. So I really appreciate the conversation. Is there anything else you want to make people aware of? Anything that we missed that you feel is important?
No, I think that it is important that, I think the most important message is symptoms associated with hypothyroidism are not unique to hypothyroidism. All symptoms, they can be triggered by other conditions. And the fact that you have dry skin, constipation, and your hair is falling doesn't mean you have hypothyroidism. So don't blame the TSH for being normal. It's just that maybe there are other explanations for the very absolutely same symptoms. And I think that we don't do a good job explaining that to patients. Patients need to understand that. And yes, many patients will have hypothyroidism, but not necessarily, not all of them. I think that's a good message.
I'm glad you mentioned this piece, because I had thought about this earlier today and we didn't squarely come at it, which is symptoms are not a reliable predictor of hypothyroidism.
Correct.
And I think patients really need to know that, because exactly to your point, they'll type in their symptoms, right? Falling hair, depression, dry skin,
absolutely.
And you'll find someone somewhere saying, well, if you have those things, it's been shown that you have hypothyroidism or you have a high likelihood of hypothyroidism.
Right.
And for our audience also, I've been a pretty big advocate regarding gut health to listen to your symptoms, right? What food should I eat? The allergy testing's not been shown to be accurate. Save IgE reactions, save anaphylactic. But for these low-level reactions, when you review the literature, IgG testing is not validated. No large bodies are acknowledging that as a way to screen for food allergies. But what can work really well is, do you eat a food and then have a symptom? So in some realms of GI, listening to your body is the way to go. There's an exception to this rule, I think, clearly here in endocrinology with thyroid, wherein your symptoms are not going to be a reliable predictor. And thankfully, we have pretty accurate lab testing to make that assessment.
Correct. I totally agree with you.
Yeah. Is there somewhere online that you want to point people if they wanted to try to follow your work or connect with you?
Yes, I have a Twitter account. It's called Bianco Lab, at Bianco Lab. I have a website. It's called Bianco Lab as well, www.biancolab.org. And I just published a book. It's called Rethinking Hypothyroidism. Some patients want to take a book and take a read. It's for patients and for doctors as well, but it goes over many of the things we discussed today.
Yeah. Well, I'm going to give your book a plug, not even having had read your book, just in this discussion. I think you're the most informed and sort of open-minded, but on the mark person I've talked to in the thyroid space, honestly. Thank you for writing the book. And for people watching this sounds like the book I would have written because we clearly we're on the same page with a lot of these topics. So that's fantastic. And Antonio, again, this has been a really great conversation. So appreciate you taking the time and all the work that you're doing to help patients, because I know you're in a contentious landscape where patients want to think it's thyroid, and when you tell them it's not, sometimes they get aggravated. But I think we both put patient well-being above telling them what they want to hear.
Yes, exactly. Thank you very much for having me. It was a pleasure, Michael.